Okay. All good. Am I waiting for anybody else? And you can see the screen, eh?
Yeah, we can see your screen, PowerPoint.
Okay. All right. Okay, we're going to get going. Like we said last time, the fractures is too much detail in an hour's lecture to go through everything. So I'm just going to go through instability. And it's going to be the TUBS group, the traumatic unidirectional Bankart lesion surgery. I'm just going to briefly say the atraumatic group, you try physiotherapy, 70%, 50 to 70% will improve, although that's disputed. Some say 70% fail. If they have surgery, 70% have been revised by 7 years. So those are the broad outlines. There's a lot you can say about this atraumatic group, but I'm talking about the most common type, the traumatic group. Okay. So when you get faced with an instability patient, this is what normally happens, and half the time they come in with their parents, because most of them are youngsters, if we see them. And so they want to know what happened to them. So you have to understand the pathoanatomy. So we're going to try and answer those questions tonight. We'll briefly discuss some imaging, what to do about immobilization, bracing, rehabilitation, whether they should have surgery or not, what surgery to do and when to do the surgery, and probably the most important question for most of the people that are coming is when to return to sport. If we look at this, the first time dislocation, there's a couple of papers that are out there, but it really is probably closer to 100% will have a Bankart lesion if they've had a traumatic event that's happening. SLAP lesions are up to 20%, which you'll see is quite unusual because most surgery doesn't address the SLAP lesion. So it's probably been overcalled. Haggle has become more prominent at 5 to 15%. All of them have some capsular stretching, and there's either a glenoid fracture, some compression or erosion, which we'll be talking about. That's from one dislocation at 41%. 40% will get a Hill-Sachs lesion. Nerve injuries about 5%. Probably if you do neurosensory and conduction tests, is probably much higher, but they're not clinically evident from them. The good thing is 95% of the nerve injuries will come. And in the older age group, rotator cuff tears are a problem. As you can see, 40% in 40-year-olds and 60-year-olds. Most of them are partial tears, so we treat them conservatively, but those patients you see with the older patients, if they've got a full thickness tear, it's probably better to have surgery than to leave them alone. I think you've got to understand some of these terms, and they're fairly simple. The Bankart is where the labrum is torn off. When there's a piece of bone, it's a bony Bankart. Reverse Bankart is out posteriorly. A Perthes lesion, which everybody talks about, is where it's actually in continuity with the periosteum along the front of the glenoid. And then the Alpsa lesion, which I think I'll show you an example, is where the labrum is pulled onto the anterior part of the neck. And the Glad lesion is when there's an articular defect as well, or disruption of the cartilage, and probably increased risk of osteoarthritis. So for those, can I ask, has anybody not seen a Bankart lesion? I can't actually see what the results are. Let's have a look. There's only 9 of you, sure, not many people turning up there. Okay. So if we look at, this is a scope from the back. So we're looking up to 12 o'clock where the biceps lesion is. This is the labrum. You can see this is relatively acute. There's a hemorrhagic synovitis, as you can see here. Here's the posterior labrum. So if you have a SLAP lesion, that's what it is, superior labrum, anterior posterior lesion. And as we come down, you'll see the labrum's about to be disrupted. Here it goes. And you can see, well, this patient is going to develop arthritis because he's got cartilage damage. One of the reasons they get ongoing arthritis and the incidence of arthritis. And if I speed this along a little bit, you'll see this patient also has a little loose piece of labrum and a Hagel lesion as well. This is a avulsion of the inferior glenohumeral ligament of the inferior capsular attachment on the humeral head. And this is what a Hill-Sachs lesion looks like. There's a glenoid. You can see the dent in the back there. This is a patient who had one dislocation, had no Hill-Sachs, and the second dislocation developed a Hill-Sachs lesion. And we'll talk about that a little bit further. Here you can see there's no labrum at the front because it was torn off last time. And now the second dislocation. The patient was in the 30s. It was a female. That's why we elected to treat her conservatively. So, I mean, unfortunately, some poor decisions were done 20 years ago, 30 years ago, probably even as little as 10 years ago. And Martin Johnson, who some of you may remember, in 2007 won the World Cup with, or was it 2003, sorry, won it with England. And in his book, he actually really has a go at the medical profession. He treated his dislocation conservatively. Then he had an operation which failed. And then he had a second operation, which actually managed to last through the World Cup. And he goes on to say he nearly missed the World Cup, and it cost him a lot of years before going there. And it was quite remarkable how such a famous person could get away with being trashing the medical fraternity. And in fact, he's probably right, because the decision-making was very poor. We'll hear about that now. If you do a Google search on shoulder dislocation, the literature is massive. I just did 2023. I just looked at remplissage, and just this year alone, there's more than 30 publications, scientific publications, not other types that are not on Twitter and stuff, with about 4 on different techniques. So the literature is just massive. It's almost impossible to keep up with. Okay. So, Dane, what would you offer this 14-year-old basketball player? And if you can see the MRI, what can you see on this?
Prof, I'm just taking a look at the MRI. We've got several axial cuts, T2 weighted in the first row, or the higher row. Struggling to identify what the lower 2 pictures are showing, but anyway, in the top 3, excuse me, we can see a large effusion in the joint.
Okay, that's probably unlikely. This is an arthrogram. Right? It's difficult to say, but this is I'm telling you, this is an arthrogram. Yeah. I mean, most effusions don't look so big like this. And if you have an effusion this big, usually there's more blood and you'll see more debris and synovitis. Yeah? But this is an arthrogram.
Okay. I haven't actually seen an arthrogram before, I don't think. But anyway, what I also note is on the anterior aspect of the glenoid there, there's some form of Hill-Sachs lesion, Bankart lesion, excuse me, Bankart lesion. I'm not sure which one it is specifically, if from that previous slide that you just showed us, perhaps the avulsion of the periosteum one.
Yeah, so it's an ALPSA. So you can see there's the labrum. Should be ALPSA, sitting yes. There. No articular defects and not a GLAD. And you see the periosteum is here, and you can see how it's peeled back and it's sitting medially. Yeah?
Yes.
So you're right. This is an ALPSA lesion. Anything else you can see?
I don't know, nothing specific, Prof. There's some fluid around the biceps tendon.
So the first thing is usually when we look at it, do they have a Hill-Sachs? There's this Hill-Sachs. Can you see he's got a bony bruise? And there's that in the top. Okay. So, and this shows us the labrum. Can you see it's peeled off there? No?
Is that
so what are you going to do for him?
Oh, there. Okay, no, I'm orientated now. Prof, I'm not speaking from any kind of sort of literature point of view, but he's a sportsman. So I believe that, although he's only 14, so I'm actually Not really sure, Prof, but I know that the fact that he is an athletic individual would need to be considered. And he's very, very young. So he's got a high risk of recurrent dislocations. So I think surgery would be in his best interests. I don't know what specifically, though.
Okay, so you're not sure to offer him an operation or not, eh?
I don't know what operation to offer him, but I think at that age and with he's playing a sport that often has above head activity when they're shooting and defending. I think a surgery would be best.
Okay, so hopefully by the end of this talk, you'll be able to decide which one you're going to do. So if we have a look, this is a portal from superiorly, and we're looking posterior on the humeral head now. So this is a superior portal. Oops, sorry. No, let's go back. Okay, so there's the hill sacks. Can you see it?
Yes.
Small hill sacks. It's mainly cartilaginous, maybe a little bit of bone dent, but it's less than 20%. Here's the posterior labrum, and here's the glenoid. You can see it's nice and round, so there's no bone loss, eh? You see that, eh?
Okay, yes.
So it looks pretty good, eh? Except if you come down here, here's the whole labrum. Can you see how it's peeled off the red part of him? So he's got no bone loss, and he's got that's an Alpsa lesion because that whole labrum is pulled medially. Okay, so we'll learn some things about that now. So I'm just going to start off about the adolescents because there's been a big change recently. A lot of people around the world are not buying into it. There was a whole session at our Rome meeting now just on the adolescent sports, and they talk rubbish. No, I'm joking. They have a different population group to ours. Okay, so if we look at it, people are doing arthroscopic Bankart repairs for these patients. I learned back 2008, 2009 that when I saw these adolescents and you did a Bankart repair, they didn't do so well. And in effect, they played rugby, I started moving away. So long time ago, and I got criticized heavily, both locally and internationally. Whenever I did speak, I could see the faces just thinking I was an idiot. In fact, Len Funk, I gave a talk in 2012 at the Wrightington meeting, and they couldn't believe what I was telling them. So Len Funk went and looked at his patients, and he followed them up. 15% followed, 15% failed at 1 year follow-up. At 4 years, 31% have failed if they're in the adolescent group. And if you look at that, so this is everybody, not rugby players. This is all the adolescents. So without playing rugby, 90% of redislocations while playing rugby again. So if you're a contact athlete, the arthroscopic stabilization, and you'll see why it's important, which I'll talk about just now. So then he followed up with an even longer article, even longer follow-up. And let me just move this out the way, sorry. And then he found if they were under 16, they had a 93% failure of the arthroscopic procedure. So if you look at it, it's almost the same as the conservative treatment over 5 years. So it failed 95% of the patients. I'm giving a blank here. Right. So this is his publication, and you can see what happens overall. Age 25, you see the 90%, above 80% was still going at 200 weeks. If you were less than if you're between 16 and 17, and if you were under the age of 16, look at the failure rate. It's dramatic. Okay, and you'll see why that's important. So this paper in 2012 said we already changed our practice in 17 to 25-year-olds. So instead of offering surgery, they now went from 16% to 71% if you were under the age of 25 that were offered and being done in the UK. So it doubled. Just offering stabilization had doubled by this point. So there's been a rapid progression to realize that you don't wait for the second dislocation, and I'll show you why. So and their paper states that rarely in the history of orthopedic surgery is such a dramatic and widespread change in operative technique occurred in such a short space of time. So it's pretty impressive that people all suddenly started operating, maybe because there was a lot more fellowships in children. This paper from 2019 then looked at all the dislocations. What they found was that the patients would be under-operated in the NHS. This trend hadn't gone into the NHS hospitals, and a lot of people were being neglected. And they found in those treated conservatively over that period was a 20% failure. And if you were operated on, there was a 20% failure. So there's some issues there about what procedures they were doing. I think offering surgery for the first time to dislocate is no longer controversial. There are multiple papers being published around the world. Even 10, 15 years ago, this Kirkley studies where they randomized them, quality of life scores improved, the redislocation rate dropped down. Robinson in 2008 showed it, and the Cochrane database already in 2010 showed first-time dislocators need to be offered surgery in certain groups, which we'll talk about now. And the reason is, if you look here, this is a patient with multiple dislocations. This is a 25-year-old rugby player. Already he's got osteoarthritis with massive cartilage loss because he didn't have surgery. Okay. So Habermeyer and a couple of other people have shown that each time you have a dislocation, you worsen a couple of things. So your bony deficiency, so from your second dislocation, you go from 40% to 80% of your glenoid bone, of your Hill-Sachs lesion, and it's bigger. And there's an independent relationship with the bony deficiency and development of arthritis and the number of dislocations. Okay. They've shown the ligaments are worse off the more you dislocate, and there are other injuries that happen. So it's certainly in the younger group with a very high dislocation rate of 90 to 100%, you should be offering them surgery first time round, but they must understand the dislocation, the dislocation surgery risks as well, which we'll talk about now. This paper in 2013 already showed that it was actually cost effective to operate on people who were young with the first time dislocation. This paper from 2019, I don't know how they got it past ethics, and it was already commented at one of our more recent meetings. What they did is they went and they randomized them to just a scope and washing them out, and a scope and a Bankart repair. And what was interesting, the people who had a washout did a lot better than the people treated conservatively, and maybe because it was removing the effusion and allowing the labrum to sit back onto the glenoid. I'm not sure why. But the repair outdid the arthroscopic washout. So the repair outdid the conservative treatment and the arthroscopic washout, but the arthroscopic washout improved them. And I'm not sure why, but that paper was published also by Robinson in 2019. So your patient is going to be asking you, when can I go back to sport? They're in mid-season. They don't want an operation because then they lose 4 to 6 months. So we've got two papers, one by a guy called Buss and American Footballers, who went back to play at about 11 weeks. After 11 days, they went back to playing sport. But just remember, their type of game is different, and their tackling technique is different, and their different positions are very different. 70% failed to complete the season, either due to pain, recurrent dislocation, or they opted for surgery. So that means 30% managed to finish the season in that study. But this more recent one from Tokish, who's done a lot of work on this sort of stuff, 2019, said it was surprising how many people managed to finish the season without many. If you had a subluxation, you had 3 times odds of a successful return compared to those sustaining a dislocation. That doesn't mean that you still don't have a 90 to 100% dislocation rate. And I've seen enough of my players who early season don't want surgery, and then 2 years later they have the dislocation, or even 3 years, and they manage to get through a season without. And there's no doubt, I mean, maybe I'll be able to look at it one day, is that those patients who decline surgery, their shoulders are worse off with respect to cartilage damage, rotator cuff tears, Hagel lesions, than the people who have that first-time dislocation. In fact, that's probably a very good study to look at, because I have scopes on those patients, on all of them. So maybe we should be looking at that. The next question they're going to ask you, should you be in a sling? Let's see who participants. Bijou, you next. What do you think about it? You put them in a sling.
I usually do put them in a sling, but I think that they're going to have increased stiffness if they put in a sling. So maybe a brief amount of time immobilized.
You must understand, why are you putting them in a sling?
It's more for pain, I think, than anything.
Yeah, so a week to two is not a bad idea for pain. It's not going to make them stiff. Slings don't make you stiff. Eh? You know, listen, if you wear it maybe for 3 months, it might make you stiff. But it's not. So you must realize why you put them in a sling. And there's another reason, is their pain makes their rotator cuff weakness. They've got fluid in the joint, so they lose their what are the mechanical force, where you've got two surfaces stuck against each other. So you've got pain, fluid in the joint, and you've got a tear. So you more probably at risk of a desiccation in the first little period, that if you're not careful. So maybe the sling does help a little bit, and it helps with the pain. But I get them to use their muscles from day one, because that's what's keeping them in the joint. So they immediately get a sling for comfort. And I told them it does not reduce the desiccation rate. And this back in 1956 was shown. And then a meta-analysis for all the slings. They even put them in 3 months in slings. Made no difference to outcome. Except they went along to a guy called Itoi from Japan, put them in external rotation brace for 3 weeks, 23 hours a day, and he halved the redesiccation rate. So suddenly we all try to start putting them in external rotation. Sheesh, if you can halve the desiccation rate, maybe doing better than some of the arthroscopic surgery that we saw from there. There are some problems with it. That's what he found, 50% reduction in desiccation. But if you put them in an MRI with the arm in an external rotation, 35% of patients didn't reduce the labrum. So what are they trying to treat? So if you think about it, it does nothing for the Hill-Sachs lesion, does nothing for the Hagel lesion. In fact, it pulls the Hagel lesion apart. If it doesn't pull the labrum back into the place, there's no point in sitting there, because it's not doing what we think it's doing, reducing the labrum to heal in a good position. And it does nothing for the capsular stretch. So in fact, it makes good sense if you're reducing the labrum, but all the other pathologies are not being addressed. And here's one of my patients. He's a 14-year-old. We put him in a sling, external rotation brace. You can see where his biceps is. So he's in external rotation. And you can see his labrum is not even close to where he was. And you can see this patient has a GLAD lesion. Can you see that? His articular cartilage is missing. And there it's pushed down. And if you look down, it's right off. It's off there. And in fact, he's got a little bony Bankart as well. Here, you can see it's off. So that's in an external rotation. So we did it for a few players. And people, when it first came out, and we promptly stopped it. Plus, they have to be in the sling for 23 days. And then 2 groups of people have done randomized studies, and in fact, it showed no difference. If you're less than age of 35, yeah, made no difference. Eh? What about physiotherapists? Let me just check here. Who's a physiotherapist from before? Let me just see. Who's a physio here? None of the old physios. Right? Vibrant, weren't you a physio?
I don't know if someone was saying they are old physio there, Prof.
Who was a physio before they did orthopedics?
It was Kirsty Berry.
I'm not.
Kirsty Berry and Matthew Workman.
No, neither of them are still here. Okay. Okay, Scott, what do you think? Physio help?
I think in select patients it might help, Prof. So if your patients with lower risk of recurrence who are not engaged in sport activity and don't do contact sports and don't have large bony defects like Hill-Sachs or Bankart lesions, yeah, I think there could be a role that I just don't know the
So you
numbers.
just pre-selected the group that are going to do well. So how are you going to tell?
Yes, yeah, well, I won't know actually, Prof. I don't know
Okay,
what the
so I
evidence
mean,
is.
you would think that if you do if you do them, what's the aim? So if you strengthen the muscles and you improve proprioception and get the correction of the scapula, we may improve. Certainly does in the multi-directional instability. There seems to be improvement, but unfortunately, there isn't a single proper paper showing that it makes any difference. So the physiotherapy is good for your muscle to return a whole bunch of things to you, but it actually doesn't stop the recurrence rate. So it is important, especially for the Ambry group. And I think it is important post-surgery, but and it depends which operation you do, but there's no evidence it actually stops recurrent desiccations. I'm not sure why it's going. Okay. So there's a couple of studies that's showing. How about bracing? Yeah? Who's next up there? Who rides motorbike? Who's a motorbike? Raymond, don't you ride motorbikes? What do you think? Do you think bracing stops desiccation?
Yeah, I don't ride motorbikes, but I don't think it's. I don't think it. I mean, I'm not sure about the literature, but I don't think it has a role in preventing dislocation.
Yeah, so bracing hasn't been shown to. Nobody's shown a bracer, but there's a lot of braces. Let me see if my next slide's up. If you look at the bracing, most of the people that you want to brace are playing a sport where if you look at it, you can't brace any of these because it's stopping you to get into abduction and external rotation. So if you look at most of the sports that we're doing, you're probably not going to make any difference. Okay. So you can see De Villiers with the brace. This guy would never need a brace. Do you know why? He never tackled with his arms anyway. So he never got beyond that height. So that guy, for the older ones. And you can see here, it may have a role in these patients, but instead of being able to extend your arm, what you're going to do is now land on the end of your clavicle or your head. So I'm actually not sure braces. We redesigned the brace, and I had a bunch of patients, and it's called the Lear shoulder brace. I get no royalties, unfortunately, yet I was the one who designed it. Nobody's proven bracing doesn't stop. Okay, so now you can tell those patients then. So which operation or how do we manage these patients? This is a review article. JAOS, there's a lot of review articles come back from 2014. And in fact, I don't think it's changed that much there, but we'll talk about some of the changes as we go along. And they came up with some recommendations, but I think you can broadly keep in together. It gives you Scott rides a scooter. Okay. Who to operate on. And it tells us who to operate on, which surgery to offer, and why operate on them. So I think it's worth reading that article. So they come to the conclusion that if you're under the age of 25, you male sex, competitive sport, and contact sport, and you have more than, so you have one desiccation in that first group, and then if you have more than one recurrence. I think we're going to see a changes as we see the increase in the uptake in rugby and contact sport by more and more females. And plus we'll talk about desiccations in male and female just now. So that's the group. And then they recommend if it's more than 20% glenoid bone loss or an engaging Hill-Sachs, which is the concept we'll talk about, and that's about bone loss, you get a bony operation, coracoid transfer or bone graft to it. In addition, if you have an anterior periosteal sleeve or a haggle, they suggest an open surgery is better than doing an arthroscopic procedure, which I think is even more controversial to me, but we'll discuss with it. And then they go on to say in competitive contact athletes. So they're starting to give us guidelines on what we've learned over time, and we'll address that now. And then those with hyperlaxity, those are the conclusions, okay? And then the ISA score, which we'll talk about. So there's really two main options that most people are using at the moment, although there's a couple of additions, which I will mention as well. You can do an open or arthroscopic Bankart repair. If you speak to the older age group, they tell you an open procedure is better than an arthroscopic. It certainly was at the beginning because people were learning the arthroscopic technique, and now we've learned a couple of things about the arthroscopic technique that's improved. And in fact, in the randomized study in 2012, and subsequently to that, there's no difference. So I don't think if you do a good arthroscopic procedure or a good open procedure, it makes no difference. In New Zealand, they do open Bancards in their rugby players with a 70 plus or 80 plus good outcome. We do Latarjets on our patients with a 95% good outcome. So it just makes no sense for me to do an open Bancard or arthroscopic Bancard. And you decide how you choose those patients. So there's a couple of other studies proving this as well. So we're not going to even debate. You do which one's good in your hands. You can do an open one or an arthroscopic, makes no difference. So why do you choose a arthroscopic procedure over a bony procedure? And we're going to go through that. So there's an arthroscopic procedure. You put at least 3 anchors. You must get what we call a rolled up bumper effect of the labrum, and you repair it on. And this is the Latarjet. You take the coracoid with the conjoint tendon and you put it onto the front of the glenoid. So you get 3 benefits. You increase the size of the glenoid. You get the sling effect of, as you lift your arm up, the conjoint tendon comes in front of your joint. And because you go through a subscap split, it holds the inferior part of subscap down and pulls it down. And we've just published in the Journal of Shoulder and Elbow, it probably has an additional effect that the muscular forces of the change in the position increases your force of preventing dislocation as well. So probably a dynamic is an additional dynamic effect of the conjoint tendon. However, this paper in 2019, which won the knee award, which is the world's best prize for shoulder and elbow paper, they looked at people who just get an iliac crest bone graft or a Latarjet, and there was no difference in outcomes. But you must go look at the paper carefully. It includes all comers. It does not include rugby players, and it does not include, and if you look at the age group, it goes from young to older. Okay. So you got to look at these papers very carefully when you look at instability, and they should have a 5-year follow-up. Kirsten Gerber says you should not even talk about your results unless you've done a 5-year follow-up, as you could see with Len Funk's paper. And you must look at the age of this patient. So when do we do a Latarjet? It's when the Bancard's going to fail. So there you can see the Bancard. The sutures are all intact, but the labrum to the glenoid is not intact. Okay. So Joe De Beer in Cape Town with a guy called Steve Burkhardt, another famous shoulder surgeon, published this paper in 2000. It is the most cited paper in instability surgery in the world. So quite phenomenal coming out of South Africa. And what they found that if you had a significant bone defect, you had a 70% failure rate. And if you didn't have a bony defect, you had a 6.5%. The problem is, well, how do you define bony defect? So there's other aspects. So it's clear now, if you have a bony deficit, your recurrence rate is much higher. So that's the first group. And now this bony defect has changed from an engaged lesion into an on-track to a measure of a bipolar bone lesion. So you must know how much glenoid bone is missing and how much humeral head bone is missing. And then you combine them and you decide whether it's an on-track or off-track. So what it means is, if you have a Hill-Sachs lesion, as you rotate the arm, if that Hill-Sachs is still less than the glenoid width, then you're fine. You're not going to engage it. So as your glenoid gets smaller, your Hill-Sachs also can get smaller before it becomes an engaging lesion. Does everybody understand it? If you don't understand, you must talk about it now, because everybody should understand what an on-track and off-track lesion is. So you can understand. If you've got no glenoid bone loss, this tract would be bigger. If you've got glenoid bone loss, then this tract becomes smaller. So the smaller the Hill-Sachs become more important. So it's a bipolar lesion. It's all started off with what we call an engaging Hill-Sachs, which I think I'll show you here. So when the patient is asleep, you take the arm, there's the glenoid with the labral tear, and you put it in abduction external rotation, and then see there's the Hill-Sachs. if it engages in that position like that. So if it slips over the edge like that, it's an engaging Hill-Sachs lesion, then you must do a Latarjet. The problem with that is they're not taking into account the laxity. And in fact, when you come through, I will show you when you put patients through the abduction instrumentation, the anterior ligaments are still so robust, you don't dislocate in the position, you dislocate in the mid position when there's some anterior posterior instability, but we can talk about that later. In addition, you can see this patient has a bit of a haggle as well as the labral tear-off. So that's an engaging, what they talk about, an engaging Hill-Sachs. So what about the glenoid bone loss? Okay, so if you look at if you have a bony Bankart within 1 year, this group in 2013 showed that bone resorbed if you did not fix it earlier. So if you've got a glenoid defect and you want to reduce your engagement or your bipolar lesion, the on-track, off-track lesion, then you must fix that bony Bankart first. So we're just talking about that, because it dissolves within 1 year. There are other people who dispute that. They say they can find that bony piece and put it back on, so they don't have much of a bony deficit. In fact, published a year before that, they showed that if you fixed it, you restored your glenoid. So you'll see how that plays in decision-making at the end of the talk, whether you should fix it or not, okay? There's multiple papers now showing what Burkhardt shown. There's several studies saying the bone loss is important. 2008, 2006, 2004. And what did they find? Hyperlaxity. So some of the patients now starting identifying not just bony deficit, but hyperlaxity as well. So then they looked at what are the risk factors to get a bony defect in anterior shoulder instability, and you're more likely to have loss of bone on the glenoid or the humeral head with a number of dislocations. Well, we know that it's not stupid, but what's interesting, it's also age of at first dislocation. So that the younger group are more likely to have bony deficit. So, but that principle I was talking about in engaging, non-engaging, I'm going to show you here. So this patient has hyperlaxity, and I'll show you he's got a big bony defect. But here you can see. So look at the hyperlaxity. He's got elastomus, he goes out the back. Put him in external rotation now, and you see you can't pull him out the front, you can't pull him out the back. Can you see how stable he is now? So he's not dislocating, but look there. Put him in his mid position, out he comes there. Can you see that? Put him in external rotation. You can't push him out the back or the front. So people are not dislocating. It doesn't matter how big it does matter how big you're dislocating, but there you can see he's popping out and he's going into that. So people are not dislocating what they think in that abducted or hyperextended. You can see there. Can't pop them out there. So all this concept about an engaging Hill-Sachs is true if it's a very big Hill-Sachs lesion. Okay, so let me go here. This is the guy now. You can see he's hyperlax. He's got a cardiac scar because he has epilepsy. So he has epilepsy due to his cardiac issues, and he's had a Latarjet. You can see we tightened him up. And this is his 2-year follow-up clinically. So we've tightened him up. So there's his Latarjet. We've made his glenoid bigger. He's got a big Hill-Sachs. This is an engaging Hill-Sachs. Yeah? And if you look, he has a bipolar lesion. And in addition, because he's hyperlax, I learned that the Latarjets don't do so well in the hyperlax patient as well. You have to add a capsular shift because it's not just good enough. And we can maybe talk about that. So, but you can see a good clinical outcome by doing a Latarjet plus a capsular shift in somebody, and that illustrates the problem. So we know that bone loss and hyperlaxity, you're more likely to fail your Bankart lesion. And what about the different sports? So is exactly, you can either be a sprinter or you can be a jumper. Clearly, this person's chance of redislocation is much lower than this one. And this is exactly what happens in sports. we can identify them now. We have a working group of shoulder surgeons in Cape Town. We did not believe that their Bancards did so badly. So I challenged them, and JP went and phoned up all their patients. So these are patients who supposedly pre-selected already out without bone loss. So they didn't have a big Hill-Sachs or glenoid bone loss. And he managed to contact 129 out of 157 patients. And by this stage, this was 2013. So we started it 2 years before in 2011. That stage, I had already stopped doing Bancard repairs on rugby players. We did a 2-year follow-up, pre-selected without bone loss. And the recurrence rate overall was 18%. That's overall. And those who continued to play rugby was 34%. And this was a 2 to 5 year follow-up. So in fact, if you played rugby, your chance of dislocation was much higher. And these are not teenagers. This is from teenagers to older patients as well. So you've got a pre-selected group, and some stopped playing rugby. So that this recurrence rate is probably lower than in reality. So it just confirmed now rugby players. Now, internationally, there's been several other publications. So look at this, 2007. This is an injury severity score, and it's out of Pascal Boileau, who's out of Nice. So he's a very famous shoulder surgeon, looks at instability and joint replacements and lots of other things. So they came up with the score. And if you look at it, it's looking at age and what sport they play, whether they've got laxity, and whether they had bone loss on the X-ray. So this is without CTs or MRIs. And they looked at you scored them like this. So if you contact sporter, what they find, let me just go here. So if you had a score more than 6, you had a 70% recurrence rate. Okay, 5% and 10%. So if we go back here, so if you're a contact athlete, that's 2. Competitive contact athlete under 20, you already got 5. Eh? Quite a few, if they dislocate, already have hyperlaxity. So you got 6. And they're more likely, if you're young, to have a Hill-Sachs. So, in fact, if you look at a lot of the people in this group, shouldn't have been getting them on their scoring system. So they went, if your score is more than 6, you need a bony procedure or lattice. And which group is that? The young male contact athlete who plays competitive sports. So that's the group. This paper was looking at the failures after an arthroscopic Bancard repair. And their conclusion was that the younger age, glenoid bone loss now had gone from 20% to 10%, and off-track lesions, so that's now they're looking at bipolarism, and they came up with a scoring system to look at it to reduce it down. And in fact, what they're doing is they're just changing the scoring system to add CT scan and glenoid bone loss, which you weren't being done in the ISIS score. So that's what they were doing. It's just refining what was going on. Okay. So then if we just look at this, this paper looking at the, let me just move this down. So the patients who are unhappy after the Bancard. So if you look at a lot of the Bancard patients still have a sort of, they're not dislocating, but they're uncomfortable in abduction external rotation, and maybe not apprehension, but they've got pain. Up to 30, maybe even 60%, some of them. And what they found out was the size of the Hill-Sachs and how many instability events that you had before, and if you repaired a slap lesion. Slap lesions don't do well. That's why people do tenodesis for them. Okay, and that was in 2019. So it's all about the bone, it's all about laxity. And the surgical failure was age at the time of the set, the younger patient, the size of the glenoid defect, and the number of instability. And if you look, they're interrelated. If you're younger, you're more likely to have a bone defect, and the number of instability increases your risk of a bone defect. This guy's name is Christian Gerber, one of the leading things, and at numerous events, he's now retired, but he comes to the meetings. He tells us why we're not doing the lattice. So I'll tell you just now what he said. So he looked at Gilles Wash, looked at his recurrence rate less than 20% with more than 2,000 procedures. And Gerber looked at all his Bancards and the lattices and their follow-ups, and he said, you can't talk about instability outcomes unless you've done 5 years. But there's a lot of people around the world who go and saying, but you're doing a non-anatomical operation, and there's more complications. So we'll deal with those things now. So if you look at the Bankart, this is like, what do they call this? Fence jumping. I can't remember the name now. Yeah. So if you go follow them up at the first fence, they're fine. That's the first year. Second year, you've got 1 or 2 failures. And if you follow them at 5 years and young adolescent rugby players, you have mayhem. It's exactly the same as this. You can't go and look at that first fence. You've got to look at the last fence that they're jumping. So let's go look at the Lattiger because it's got such a bad name. And I think because the surgery has been really badly done. But you've got to look at the complications because the patient must understand what that's going to. So this comparative study looking at 185 is Hevelius is probably the one that changed some of my management. He looked at it and said the open Lattiger is more reliable in terms of shoulder stability than an arthroscopic repair. So these patients, when you get born, you get a number, and that's your bank number, your student number, all your numbers throughout your life. So you can be followed up wherever you are. So he did a 17-year and then a 25-year follow-up on all the patients who had instability from conservative to and all the different surgical options. Let me just quickly go back to them. What he found was that if you had instability and you became stable by yourself without surgery, your arthritis rate was, I can't remember what the percentage was, but say 10%. If you had surgery and you became stable, you had the arthritis rate was the same if you had a good operation. If you had a Lattiger, that rate was the same as the people who didn't dislocate again, if it was done properly, and you added something to the capsule. So they did better than the group. If you had a Bankart and you were still painful, your arthritis rate was 30% more than the other one. So maybe not 30%, but there was, I can't remember the actual, that other figure. Your Bankart failure, the painful Bankarts had more arthritis than the Lattiger patients. So the best outcome was in the Lattiger with a capsular strip. And lots of people were not repairing the capsule. So that's when I started repairing the capsule. And I saw those failures in the hyperlax patients. So I made sure that I did a bit of a capsular shift with them as well. So that's the Hevelius paper, a long-term follow-up. 2014 with a 6-year follow-up, the Lattiger had better scores than the Bankarts. And if you did competitive sport or you had hyperlaxity, you had worse outcomes with the Bankart and much better with the Lattiger. And if your ISA score, remember, was 7, you did badly, more than 6, if it was 7 or more. Now they found that if you're an ISA score more than 3, you probably should get a Lattiger. And there are several other papers now supporting that ISA score of 3. So that essentially means you're under the age of 20 and you have a dislocation and you play any sport, you need a Lattiger, which is essentially where some of our thought process that's been going on. Okay. Sorry. Let's go there. Sorry, I'm having a bit of a problem with my slideshow. Okay, so this is one of the patients. I've got 3 patients who've had a Bankart and Lattiger. This is at 6 weeks and this is at 3 months. So they had surgery. You can see he's got a Lattiger on the right and a Bankart on the left. And the reason they chose this, we had long discussions with all 3. They were all rugby players. They were all fly halves or scrum halves. Well, 2 fly halves, 1 scrum half. And on the side, they had the Lattiger. They had a true dislocation, so worst outcome. On the other side, they had a painful shoulder with a labral tear. We went through the decision making, and they decided to have a Bankart and a Lattiger instead of bilateral Lattigers. I have done bilateral légers before. And you can see very good outcomes. All 3 patients say the Latarjet beats the Bankart hands down. Yet the Latarjet side had the worst pathology on scanning. So in my little series where I can really compare them well, there's no doubt. So just briefly to mention, you can manage the Hill-Sachs. You can ignore it and treat the labor pathology. So you can do a Bankart, but we know they fail. You can disimpact it with or without a bone graft and leave the cartilage. Most of us not doing that. It's a difficult operation. You can put a prosthesis. So if it's more than 40%, then maybe they need a replacement. You're certainly not going to do that in a young person. We'd rather do an Eden Hibonite or a Latarjet and what we call a remplissage, which we'll talk about. Or, like in most cases with the Hill-Sachs, we just do a Bristol Latarjet or the Eden Hibonite procedure. You can tighten them in the front, so they did a putty plat, but they get rapid arthritis. Or we can add a remplissage, which we'll talk about just now. So here's the remplissage. So what you do is you fill in the defect at the back. It's basically a rotator cuff repair into the Hill-Sachs lesion. And this has become extremely popular overseas and in America. Everybody's doing it now, and there's a lot.
I think Prof's computer just went flat.
He's going to need his charger for the 130 slides that's left.
Yeah, I think his battery went flat. It looked like he stood up and plugged it in, and then
Yeah, he just WhatsApp me. Tell him I'll be back soon.
otherwise everyone well. Only 9 out of 16.
9 out of 19.
Disappointing turnout.
I'm subtracting the junior consultants who just qualified.
Oh, Kim's on here.
Yeah, but she didn't just qualify. She wants to still learn.
She's a senior junior consultant.
She's SJC.
Cindy's on leave.
It's no excuse.
Edgar's on call, and probably, or maybe Nicola's also on call at Red Cross, and yeah, in case they might be doing hands. So not bad. 9 out of 12.
Zama?
I don't know. She's trapped inside Maitland. What happened to all the Wits and Stellenbosch people who used to attend?
They know everything now. So
Enthusiasm's fading at the end of the year.
I think they're a bit tired of hearing me talk. Maybe we'll see if they all attend next week. Please tell me. It must be me who's the problem. Eh? Sorry, sorry about that. Let me just get it. Shame. Okay, so what I was saying, so remplissage has become very popular, and it's basically because people don't like doing the Latarjet because of the complications. And so now they want to do the remplissage. So they've done some biomechanical studies, now some clinical studies, and some long-term clinical studies have shown that if you have no bone loss or less than 10% bone loss and a remplissage, you decrease your you decrease your instability, you decrease the pain that those Bancards were getting that I told you in abduction and external rotation. And they even put in contact athlete, but short-term follow-ups. And I don't think they're South African rugby players. So they must be somewhere else because they're not, certainly not our group of players. Okay. And they have lesser surgery and fewer complications. That's what their studies. If you look at the studies, the average age is about 26. So you're adding all the groups with 30 and 40%. They have a lower rate. So you've got to actually look at the target group we're looking at, young patient, contact athlete with hyperlaxity and bone loss. So I'm not sure. So it's an arthroscopic procedure, so it does have the benefit that you don't have to do an open procedure. I'm not sure that little cut makes any difference. But there's some studies showing you're losing abduction and external rotation range, which is bad for an overhead athlete, not just for performance, but also for pain. So there's concern about the remplissage, but most of them say they must have no glenoid bone loss. Some people are doing it up to 20%, but it must be an on-track lesion, so not an off-track lesion, and it must, everybody says less than 10, most people say less than 10% glenoid bone loss, okay. Okay, so that's what I was telling you about. There's better scores for mobility, stability in the remplissage group. And there's more and more studies, and they're showing them in Rome, all very proud of it until Christian Gerber stood up and then told them what is critical bone loss and what are they talking about. Then it was very quiet after that thing. So who gets a Bankart athlete? Who gets a Bankart repair? Yeah? In my mind, and I think from the literature, I think it'll support, it must be a non-contact athlete. If you're going to do a contact athlete, they must be aware of the failure rates and they must not have bone loss. If they need external rotation, I'm not sure. They say you must do a Bankart lesion, a Bankart repair. But I disagree. I've got water polo players, cricketers, and overhead players. And if you look at Gilles Walsh's group, they play a lot of handball. And if you look how they put their arm in abduction and external rotation, and he has very good results and published on it. So I'm not sure that a Bankart repair gives you better external rotation. I agree, there must be minimal or no bone loss. Certainly you must use an on-track, off-track decision-making process, I think, if you're not going to do a Ladegé. And in those patients, if you have a bony Bankart and no significant Hill-Sachs and you're not a contact athlete, then I would do a bony Bankart repair despite the bone loss, as long as it's not eroded away in second desiccation. I think you can add a remplissage in a non-contact athlete if the Hill-Sachs has been in 50 to 30% with no glenoid bone loss. And in fact, if you have a Hill-Sachs, very often you have glenoid bone loss, except in the older patients. So my experience is I've done a few replissages, usually the older patients in the 40s and 50s, surprisingly the anterior glenoid, or they got a glenoid bony injury, then I would do a remplissage as well, because I think they have slightly better outcome. It's actually not particularly difficult. It's a rotator cuff repair. It's an all inside rotator cuff repair, so it's not much of a problem. And at one stage, I'd revised more remplissages than I'd done, and they weren't mine; they were from other places. So I saw a bunch of failures. The other thing is the advantage of doing a scope. You can see other lesions. Here's a type 4 slap lesion as well, and that's why we do the operation. So who do we do Ladegés for? It's not just for the French, because that was all the French who popularized it. I believe it if you've got bone loss. Certainly, if you have an off-track lesion and you're a non-contact athlete, if you have an off-track lesion and you're a contact athlete, you should get it. In those patients with anterior glenoid bone loss of more than, people now say 13% is the critical bone loss. Although it's disputable, I think it depends on what sport you play. So if you play, depends what sport. If you have hyperlaxity, I don't think a Bankart is the ideal answer, even with the capsular shift. And finally, if your life depends on it, I'd rather have a Ladegé than a Bankart. So those are the group of patients that we're going to consider a Ladegé for. So remember, glenoid or humeral bone loss, and it must do an off-track, on-track lesion CT scan. If you play contact sport, if you're hyperlax and if your life depends on it, I would do a Ladegé. And you discuss it with the patient, because some want stability, some want a smaller operation, some want range, so you talk about them or what they to do. So what happens if you see a patient with a first-time dislocation? So you must discuss with them what they've got, what they're most likely to have, and the natural history. So if you're a 40-year-old, your chance of redislocation is 20 to 30%. If you don't go kite surfing by yourself and you lead a quiet life, no surgery. You must reconsider if you free climb mountains, then you must reconsider what you're going to have. So you discuss them. If they decide they want surgery and you've got plain x-rays, if you can see a Hill-Sachs lesion and they've got a confirmed dislocation and you do the ISIS score, then I don't think you need further imaging because we routinely scope them. So I'll tell you about that now. So the scope adds probably a slightly increased risk of infection. It takes a little bit longer, and it certainly adds to the cost. But we've seen the MRIs that miss slap lesions, Hagel lesions, which need to be addressed at the same time. So we believe that you should do an arthroscopy. If you don't have it, then you've got to make the decisions on your clinical examination, your plain X-ray, and if you have access to CT or MRI. But if you've got access to CT and MRI, then why not just do an arthroscopy? So it depends on what your philosophy is. So that's if you have a dislocation. You then discuss with them the failures of the Bankart repair compared to the complications of the Lattiger, which I think I missed some slide. Maybe I'll have to go back and look. And then once you've had that discussion, then you decide which operation you're going to have. If they decide they're going to have a Lattiger, then you do a scope. So the decision to have a Lattiger, score of 7, probably 3 if you're an adolescent, what level of activity you do, and if there's bone loss, and that's when you need to do a CT. You can do an arthroscopic evaluation of the bone loss, or you can do a CT scan. The next step you decide, are they hyperlax? So if they're hyperlax, then you must consider preferably a Lattiger. So the treatment is they want to have conservative treatment. That's when I start scanning them, because if you have a CT or an MRI and you see a bony Bankart in the younger patient, I'm going to advise them to get it fixed because we know it can reconstruct the glenoid and may prevent them having to have a Lattiger, and it will definitely decrease the risk of redislocation and other pathology. Or if you've got very good x-rays and you're an older patient who you're going to treat conservatively with no big bony Bankart, you can't see a bony Bankart, or you can't see a big Hill-Sachs, you do an ultrasound to include the rotator cuff tear. If they've got no rotator cuff tear, you treat them conservatively. Immobilization is for comfort. Physiotherapy, I do advise because it probably gives you quicker stability by restoring your strength and proprioception, and probably your scapular stabilizers, and then finally your mobility. Bracing, maybe these new braces now with the different designs may reduce it. I have a bunch of kids who did try it and finished the season, and they say they felt it worked. Most of the kids, if they get strapped up, the teenagers, and actually not just the kids, the youngsters who in the 20s who are playing rugby, actually a lot of them feel that they feel much more stable in the brace, so I'll let them do it. It's maybe a sensory supply coming from the skin. If they decide not to have surgery, I like to see them at 2 weeks, and if they've got ongoing pain, you're missing a lesion such as a slap lesion, a cuff tear, or a Hagel or cartilage defect. So if the dislocation is not confirmed, but you suspect it might be, and you see nothing on X-ray, usually they're too sore to see, then I'll get an MRI scan, because the MRI will then dictate what the management is, whether you can see Hill-Sachs, Hagel, bony Bankart, or other lesions that they sometimes get. Here you can see this patient's got a partial thickness cuff tear and a slap lesion. So that's the decision making if you've got a dislocation or not. Right, where was this? I think I just maybe missed it there. Where did I miss that? So there are the complications. Okay, so I must have moved the slides somewhere. Let me have a look. So I thought I had a complication. They must have cut them out. Anyway, it's fine. Okay, so we've done an hour. That's enough. Any questions?
Prof, I referred a patient to the upper limb clinic, I think about 2, maybe 3 weeks ago. It's a young guy who's a professional rugby player, has got a contract who wanted to go to America with anterior shoulder instability after a single dislocation. And just the question with him was, so I think he needed a lat J,
Yes.
but he wanted to return to play, or basically start playing in January of next year. So in that case, what would you like if you have a athlete who wants to return to sport within a month or 2, almost like Ibn Isabet, what would you counsel them on? How would you approach that? Because obviously they need an operation.
He must make the decision what he wants to do. If he wants to play rugby again, his chance of redislocation is 100%. That's the rule. And in fact,
yeah, it's just a matter of when, basically.
He must that it will happen in the next 2-3 years. The problem is it could be in the very first game he plays. Each time he comes out, he dislocates more. But if you took some time with him, because we saw him, he's actually been subluxing, and every tackle there's a bit of feeling, and he's not great. And if you put him into apprehension, when you did him, I think you gave him quite a long thing. He's got obvious apprehension, and he's uncomfortable.
Yeah, you could basically apprehend himself in external rotation,
and we scoped him, and he had a lat J already. We had space on a Monday afternoon, so he's been done and dusted.
Okay, great. So do you think he's going to play in January?
No. So he's returned to play. So I got a PhD student who's now just looked at all return to play protocols. Just done it. She's done a Delphi study with me. And we looked at all the literature. Most people are saying 4 to 6 months. There are 1 or 2 reports of maybe 3 months. For me, 3 months is a bit early because for 2 reasons from what the lat J I do. The first is I like the labrum to try and heal, so 4 months. And secondly, when you transpose that coracoid, that bone becomes soft. It's trying to heal and unite. And I think at 3 months, I'm not sure it's united enough to go and take that contact. So I'm not keen on them going back at 3 months. It's a bit to go back, but the first game was at 14 weeks against the All Blacks. So if you had to test a shoulder, that was probably the biggest test that you're ever going to have in New Zealand. So I prefer a 4-month protocol. If I look at most of my patients, they are at 3 months, they're not ready to play. And to be ready to play, you must have certain criteria: 90% range of motion, more than 90% of strength, no apprehension, no pain, and really doing well. And they must have a mental aspect to it as well. And that's some return to play criteria or plan. There's a start program, and that's what we were looking at. So there's quite a lot of it, and especially at this level of the game now, sure, the return to play protocols are massive. I mean, what they're doing for them, and make them jump up and do this and do that. If we look at so it's a better than elite athletes. They get a serious rehab, biokinetics, and physician, physios, strength trainers, nutrition, and everything else. So they're in a good. I look at most of my teenagers who schoolboy rugby players and the Varsity Cup, and they don't have such access to all that sort of stuff. But by 4 months, 80% are returning to play because then the lat J does so well. So if they just get moving early and do the rehab, most of them are returning to play by 4 months. So that's what I tell them: 4 months return to play. That answers your question.
Yeah. No, thanks, bro.
Yeah. So he got done. He was lucky. There was no trauma on that Monday afternoon. He came in on the Monday. We offered him surgery in the morning because there was no trauma, and he got his lat J.
Prof, when do you consider doing even net on rugby players is purely based on the amount of glenoid bone loss, or the other factors as well?
So the inhibit is reserved for failures. So if you ever failed Labergé. The only other time I do inhibit are on the chronic dislocations, because if you do the chronic dislocation, you take away the coracoacromial arch and the coracoid, you lose anterior superior instability, and I think that's one of the reasons they fail with Labergé. And the second group is a group that I'm not sure what happened to my slides. I'll see if I can find them. Maybe we can search something. There's a search. We looked at all the complications, and we identified those who are at risk: epileptics, drug addicts, alcoholics, females. They're at risk. So there you may consider Remplechars and the Hill-Sachs. Or when you have a very big Hill-Sachs and glenoid bone loss that's too big for the bone reproducing the size of the glenoid, then I think you probably should do an inhibitor. And in fact, nobody's really shown how big it is. Probably a 40% Hill-Sachs. But I mean, I have people, non-rugby players, who have 40% Hill-Sachs. People who have 20 dislocations. They would just do a Labergé and a capsular shift on them. Well, more of a Bankard repair as well. So even having, but I mean, if you look at America, they put a fresh frozen tibial allograft in there, and then people put ilia crest, and people call what they call a J block. They don't even use screws. They make a little sort of bony defect in the neck, and they have a little J-shaped piece of bone that they plug in and they tap it in there, and their results are pretty good. But it's not the South African group of rugby players. So you've got to look at the population you're dealing with. And Bankard repair is a good place for people with no bone loss, no hyperlaxia, and non-contact athletes. The rest of them, 80% of my population are contact athletes. And at Grooteschuur, I would say more than 80% have at least 3 dislocations. Once you've had more than 3 dislocations, your failure rate of the Bankard is much higher. Plus, and probably the reason is you have a big Hill-Sachs and anterior glenoid erosion. Each time you go out, you lose more than anterior glenoid. So that's why we do so many Labergés at Grooteschuur and private.
Prof, may I ask?
Sorry?
Prof, I just want to follow up. So I'm interested to know, what was the final answer with the 14-year-old basketball player? I hope I didn't miss it. And then just to go with that, so when would you start thinking this patient in front of me is actually too young to start doing bony procedures or even soft tissue procedures?
So at our Rome meeting, we had a whole session with some very big names that were at the meeting, and also from the reading and my own experience. So the difficulty for me is in the immature youngster. So if you have a 15-year-old who looks like Skulk or Groenies, they get a Labergé. And if you look at half the rugby players who are 15 and 16, they're not far off those two. So they get a Labergé. There's no doubt. They fail. My son had a Labergé at 16. I believe in it. If you do, so I've just done a kid now who's the chromium growth plate is still not ossified. His coracoid doesn't look big. He's got an open growth plate on his humerus, but he's 6 foot and he's 15 and he plays rugby. And I said, I don't want to do a Labergé, but I know his failure rate, I told him, is 90%. So if you look at Len Funk's study, I think, so I go a little bit slower than rehab than the others. They let them back at 4 months. My son also had a Bankard on the other shoulder, and I made him really take off rugby for a year. Probably 9 months he was away from it. Because I think that there's no study showing that labrum heals on properly. I don't think it does. You never have the same healing. So if they're immature, And most under 14s are immature. If you look at the literature under the age of 12 and over the age of 12, there's two different series. The one says that they don't desiccate so much under 12. That's not true. We see very few, so I don't know. If you look at some of the other literature, it doesn't prove it. You must do an MRI. If they've got a big Bankart lesion, I think they must be sutured. Because you don't want them to keep desiccating from 12, 13, 14. So if you're 14 years of age and you've got a Bankart, even if you have surgery, your chance of desiccating is high if you do a Bankart. So therefore, I'll give them option of conservative treatment. They may last 2 years before their next desiccation. Then you do a lesion. If they decide for surgery, I'll do a Bankart. So that's the group. Unless they've got a big bony defect, and then I think I'm probably going to do a lesion. But they don't generally have it. They've got a, what they've done is a Bankart, but it's a cartilaginous Bankart. They take a bit of the cartilage because the glen is not fully ossified. So they have a bigger Bankart, but it's not a bony Bankart. Unfortunately, I didn't come away from that adolescent, what to do with it, a whole session on adolescent dislocations. I didn't come away, and none of them, not one single person presenting their data, discussed Len Funk's paper, because all of them were advocating an arthroscopic procedure, either a remplissage and a Bankart or a DAS procedure. And the DAS is where you take the biceps, you cut it off the glenoid, and you re-route it through the subscap and put it as a labrum onto the front end. You increase the labrum side. So you get the dynamic assist of the biceps as you go through subscap, and you increase your labral size and tissue. So that's what they're all in. And that's when Christian Gerber stood up and asked them, what is critical bone? He basically told them critical bone loss is rubbish. Got nothing to do with it. It's hyperlaxity, it's contact sport, and your labrum doesn't heal on as good as a normal labrum. So I'm not sure if that answers it now.
Oh, it helps. Thanks, bro.
If you go to America, they'll do a Bankart. If you go to France, they'll do a lesion. If you go to New Zealand, most of them will do a Bankart unless they've been well educated. Then they'll do a lesion. Now, the New Zealand guys fight about what to do, and so do the Australians. I got the one guy almost wanted to punch me at the Rome meeting because I said, no, you got a 16-year-old rugby player who's mature, he gets a lesion. How can you do it? He told me it's a barbaric operation. He told me it's a barbaric operation. So he's condemning all his 16-year-olds to another operation, 90% failure. He said they don't fail. So I said, what's your 5-year follow-up result? He said, no, they do well. So he hasn't got a 5-year follow-up. So.
Well, that's what I told the rugby player's got to go to America, Prof. I told him he'll probably dislocate and they'll do a Bankart for him and it's going to fail. So you should probably get a lat J and then go over.
So in fact, the ABC fellow was out here last time. His name's Matt Provencher. He's written a bunch of papers, and he's come to the same conclusion. If you go to him, you'll get a lattiger. So there is now a group in America who are doing lattigers, and half of them have done fellowships in France, and they go back, and the other people have studied their own literature. So Provencher came out here and he talked about all that posterior instability work. Remember? The shape of the glenoid and the acromion, and went to do a bone block. You remember, he was in the department a year and a half ago. Matt Provencher with the ABC thing. He does lesions. They do. But a lot of Americans are using the iliac, the tibial graft. Eh? Why change an operation? The Latarjet results are well published. In a contact athlete, they do 90% return to play. I mean, you lose a second season because you go out. Look at the ACL. Look at old Snyman. Look at the ACL guys. Look at Loet de Jager. He had a second dislocation. I didn't do his first one. But I mean, if you look at the second, they lose another season at 4 to 6 months. Eh? And the Latarjet results are well published. Eh? And 25-year follow-up showing your arthritis rate. If it's done properly, the arthritis rate is the same. People stabilize without surgery. So a well-done Latarjet is a good operation. A badly done one is a disaster. That's what everybody goes against. I can't remember where I don't know where I put all my complication, but if you have a Latarjet that is put, the graft is put proud, or they go septic, or you do, if you get osteolysis or it fails or the bone graft breaks, it's not the end of the world. You can do it even Nibenat and the Bankart repair, which I showed in the failed Lattiger thing I did last year. But a badly done graft in the position is they get OA. I've got a 19-year-old who's a Springbok 7th player. He's got OA. It was a graft they put in the wrong position, not by me. Somebody else. It's 20 past. Last question. Any questions? Who's FM?
It's Fidelis, Prof.
Fidelis, yeah. Now, this is recorded, so you can get this from the rest.
Oh, okay, thanks.
Okay. I hope you all now have a clear understanding about instability, shoulder dislocation, first time dislocation. Okay?
Yeah, thanks, Prof.
We'll see you at the next.